Does micronized progesterone or natural bioidentical progesterone cause cancer? Well, you've heard me and others say that hormone replacement therapy does not cause cancer. And I truly believe, based on the literature, that it doesn't. However, the details of what you're using and how you're using it matters. And this is where papers still come up on a regular basis, even today in the literature, that say that hormone replacement therapy is associated with an increased risk of cancer, or at least that's how it's interpreted. So recently, a paper that came out in February of 2025 was brought to my attention because it made a lot of my patients nervous. And I'd like to review this paper with you for two reasons. So one is that they do a great job of reviewing why estrogen, and specifically estradiol, should not be considered to be cancer causing. They go through a great list of arguments, and I want to go through those with you as well, so we can really just, let's concrete this concept. But the second thing is they talk about micronized progesterone and progestins, and they make an argument that progestogens, which would be both of those things, progestogens could be considered to be causative or increase the risk of developing cancer. So what I really want to get into here is the difference between micronized progesterone and a progestin, and separate out the claim that progestogens, which again is both of those things together, progestogens are the causative agent. There's some great literature to review that would help us to determine whether or not it's the progestins that are likely causative, or is it micronized progesterone can be included in this? And I want to review the data which they use to help make the claim that micronized progesterone could actually be increasing our risk of cancer. So if you're using hormone replacement therapy, if you're using micronized progesterone, which is also called Prometrium, the brand name commercially, if you're using these products and you have concerns about their safety, specifically as it comes to cancer, please watch this video. I'm going to go through this data in detail, and hopefully that'll help you to not have this concern. Okay, here we go. Let's talk about this paper. So this paper was published in February of 2025, and this is a couple of authors who went through the process of peer review to discuss the topic of hormone replacement therapy and cancer. So 200 plus citations. They did a great job of reviewing the literature, and they go through in great detail their arguments around estrogen and progesterones, so literally progestogens, both the synthetic and the bioidentical form. And I want to go through some of that, but we'll start with the estrogen side because, again, most people still believe estrogen causes cancer. Let's look at their arguments about why that's unlikely to be true. So they start off the paper by making the argument that estrogen alone is not particularly proliferative. Now, we know that it will cause proliferation of some tissue, but the question is it the estrogen causing it, or is it the cellular impact? Is it because estrogen will cause progesterone receptors to come to the cell surface and then be available for progesterone? That's what happens as women cycle, the back and forth of the estrogen and progesterone between the follicular and the luteal phases. So when it comes to hormone replacement therapy, exogenous hormones, if we're adding just estrogen, they'll make the argument later, if you add just estrogen, you don't see as much proliferation as if you add them both. The question is in what form and in what dose does it actually matter? But they make the argument at the beginning here to say that from a cell perspective, it's the progesterone receptor which is going to play a big role in the mitotic nature, meaning the actual number of new cells that are produced. So progesterone is going to play a role here outside of what estrogen is doing from a quote unquote proliferation perspective. And they use some examples to say that we know this is true, because if you look at certain studies that have used high doses of estrogen by itself to even treat estrogen receptor positive breast cancers, you do not see proliferation of that tissue. In fact, you actually see it withdraw, because if you exclude the progesterone side of it, then the tissue is not going to continue to grow. And so just an interesting perspective that if you look at the extreme, meaning high doses of estrogen, it actually causes that tissue to withdraw or to shrink rather than increase like we would think that it would if it were only estrogen that were causing this proliferation. And again, they also point out some studies that would show that in estrogen deprivation tissue, meaning tissues, usually this is from a breast cancer situation where estrogen has been deprived, probably both surgically and chemically through pharmaceuticals, and then you reintroduce estrogen, you actually see cell death of the cancer, again, not proliferation of the cancer, because we're only working on one side of the equation between estrogen and progesterone. Now, they also go on to talk about the breakdown products of estrogen, the metabolites of estrogen, the 2,4,16-hydroxy, and they essentially say that yes, there is some evidence to support the idea of looking at these, but what they really mean is still controversial. And I agree with that. It is controversial. We still use that tool on occasion, but we don't use it universally for all of our patients. And then they go on to talk about oral birth control. Now, this is an interesting area because oral birth control, or potentially some of the other routes of birth control, can be divided into two major groups. You have estrogen and progestin products, and then you also have progestin only, because women are still making estrogen if they're cycling. And so now we can actually look at the difference between the risk, specifically of cancer in this case, between these two products. And as it turns out, if you look at these large cohort studies, the progestins, not the estrogens, seem to drive cancer risk in contraceptives. And of course, they talk about the Women's Health Initiative. How could we have this conversation without talking about the Women's Health Initiative? This is the study that, quote unquote, showed that estrogen causes breast cancer. But if we look at the data, we can very clearly see that it's the combined group, meaning estrogen and progestin, specifically CEE, Premarin, conjugated equine estrogen as the estrogen, and MPA, hydroxyprogesterone acetate, which is a progestin, a synthetic progesterone. Those were the two forms used in this study. And in the combined group, there was a marginal increase in the risk of invasive breast cancer. Didn't meet statistical significance, but it was there. And it actually did become significant later as they followed this patient population, but it would still be considered a rare risk, a rare side effect, if you will, because of the numbers, but it was still there. So that risk was present, but minimal. You don't even have to argue that at this point. What you need to look at is to say that the CEE alone, the estrogen alone, did not carry that increased risk. In fact, it was protective to nearly the same degree of breast cancer as was the combined group. So the WHI actually never showed that estrogen causes breast cancer. It showed that HRT in those forms might have an association with an increased risk of breast cancer, and that is still debatable. Then they go on to talk about this interesting phenomenon for fertility treatments. So fertility treatments like IVF and other treatments will markedly increase your exposure as a woman to estrogen. And what's interesting is if you look at populations of women who have gone through this, there is not an increased risk of cancer associated with these treatments. In fact, it might actually be protective. And so again, if estrogen caused cancer, then you would likely see an increased risk of cancer in these populations, and we don't see that. They go on to talk about another population of women, which is women who have undergone removal of their ovaries, or oftentimes this is removal of ovaries and the uterus at the same time. So this is a complete hysterectomy. And I've heard some people use this data to actually make the claim that estrogen is potentially dangerous. And if you look at this population of women, you see that they have a reduced risk of cancer. However, if you look at this population after they've been given back estrogen-only HRT, which is common because they don't have a uterus, and the standard of care is to only use progesterones or progestogens when the uterus is present. So oftentimes these women are given estrogen-only HRT. And when you look at this population of women who've undergone total hysterectomy, they're given back estrogen-only HRT. There again is not an increased risk of breast cancer. So again, estrogen unlikely to be the causative agent here. So they go through this, very extensive review of the literature and why estrogen doesn't seem to be the causative agent behind breast cancer. And I agree. But then they make the claim then that progestins are the causative agent, but they actually don't say progestin, they say progestogen. And this is important because progestogen, like I said in the beginning, means both micronized progesterone, which is the bioidentical form, as well as progestins. So now we have the entire umbrella, progestogen, which includes all those things. Now, my experience with looking at the literature around micronized progesterone is it is not associated with an increased risk of cancer. But they cite one study that shows that if you use it for greater than 5 years, there is an increased risk. So I want to review that study, and then I want to review a couple other studies that specifically look at micronized progesterone so that we can try to make a decision around whether or not there's signal here that would indicate that we are potentially putting people at risk with micronized progesterone, because that would be new to me. So the study they cite is a 2014 retrospective cohort in 78,000 women. So, all right, this is a big study, right? But remember, this is retrospective. This is looking at what happened in the past and trying to find associations. So this is not an intervention study. We can't label causation as a result of this, but we can find patterns. So this isn't wrong to look at this population this way. We just have to understand what we're looking at. Now we have to remember what we're looking at with retrospective studies, right? So we are relying on the population to self-report what they were taking, which is a big problem, especially in older women, because let's face it, cognitive function declines as we age across the board. So asking women to go back in time and think, what was I taking 8, 10 years ago? This is problematic. And I know even in my own patients, when I ask them, and my patients are very involved in their care, when I ask them, oh, well, remind me what you're on. If they ask me a question, I don't have their chart in front of me. Oh, remind me what you're taking. Oftentimes they don't know, or they tell me incorrectly. So whenever a study uses self-reporting of products, I'm concerned that we're not getting an accurate look at what they were actually taking. So then they took this information about what women were on, and then they divided them into 3 groups. So they divided them into an estrogen-only group, estrogen plus progestins specifically, or estrogen plus micronized progesterone or dydrogesterone. And this is a problem because now we're not actually just looking at micronized progesterone by itself. We are adding another synthetic progesterone to the mix. So we don't really know exactly which of these 2 things is going to cause this signal, if it's even there, because now we're putting both in one bucket. And so again, what their takeaway was is that if you use that combination, so one of those 2 progestogens and estrogen, not the clear progestins, but micronized progesterone or dydrogesterone, if you're using one of those 2, with estrogen for more than 5 years, there was an increased risk of a development of breast cancer. So what does that tell me? Well, unfortunately, it doesn't tell me a lot. I really wish they would have divided those 2 out, because right now we just simply don't know. Is there signal? Yeah, there's signal. But what does it mean? Well, fortunately, there's more data that we can look at to help us differentiate, is micronized progesterone potentially risky here? So let's take a further look at this next study. The next study I want to look at is the PEPI trial. So this is going back into the 1990s. So this was a 1996 publication that was a 3-year multi-center randomized control trial. So now we're actually using a forward-looking trial. We're identifying whether or not something is likely to be causative. So we can actually look at the causation side here. Now, this was not as large of a study because massive randomized control trials are extremely expensive to run, but this trial had about 600 women in it. The primary outcome in this initial publication was endometrial hyperplasia. What does that mean? It means the endometrium, the lining of the uterus, getting thicker with different formulations of HRT. So they used an estrogen alone group. They used an estrogen plus MPA or medroxyprogesterone acetate group, and they used an estrogen plus micronized progesterone group. And that's it, right? So we have these 3 groups, and one of them is combined with progestin, the other one's combined with micronized progesterone, the bioidentical progesterone. So what did we see? Well, no surprise, the estrogen alone group saw endometrial hyperplasia. This is one of the studies that helped us to identify, look, we need to use progesterone if we want to offset the hyperplasia, if we want to offset the side effects potentially of breakthrough bleeding, hyperplasia, potentially even leading down to endometrial cancer. So this is why we make this recommendation to use progestogen of some kind if you're going to use estrogen for women that have an intact uterus. But now we can actually look at the difference between the MPA group in the micronized progesterone group. Now, what's interesting is that in this trial, they actually used micronized progesterone in a cyclic form. And I've done other videos on cyclic progesterone where some people say this is, fringe medicine and that, we shouldn't be cycling progesterone. There's no evidence. When you go back into the early 2000s and 90s, most of the studies actually used cyclic progesterone protocols. But what's good about this is that it helps us to identify that, look, even 12 days out of a 28-day cycle is enough to protect the uterus with 200 milligrams of micronized progesterone. So this study actually helps us to show this. Now, there was no difference in this study between the micronized progesterone and the MPA when it came to protection of the uterus, which again reinforced the idea that we can use these progestins, and that was, of course, taken on the commercial side with more and more people using and increasing the market share of the synthetic progesterone. But at least we can say we know that 200 milligrams of micronized progesterone 12 days out of a 28-day cycle is enough to protect the uterus. But that doesn't actually help us with the question at hand, because the question at hand is, does micronized progesterone increase our risk of cancer? Now, unfortunately, PEPI wasn't big enough and probably wasn't done long enough to identify cases of breast cancer, right? It was 600 women followed for 3 years. So it's probably just not big enough, because while breast cancer is common within that group, you're not going to see enough cases to be able to make a statistically significant measurement that would show difference between the groups. But they did publish another study in 2003 that looked at mammographic density. So what does that mean? Most of you probably heard of dense breasts, and you've been told that dense breast is a risk factor for breast cancer, and that's true. There's a couple reasons for that. I'm not going to dig into the details there or why that's controversial, but we can use it as a surrogate marker of breast cancer risk. So what did this 2003 publication show? Well, it showed that medroxyprogesterone acetate, MPA, and micronized progesterone both increased breast density compared to estrogen alone. So does that mean that they are both associated with an increased risk of breast cancer? Well, we can't really say for sure because, again, they didn't carry this study on to look at an incidence of breast cancer. It wasn't big enough, wasn't long enough. But what we can say is that the MPA caused more breast density, measurably, objectively more than micronized progesterone alone. So now we can say, if we're going to use this surrogate marker of breast cancer, MPA looks quote unquote worse than does micronized progesterone. Therefore, I would rather use micronized progesterone. So not a slam dunk. It's not really answering the question I wanted to answer, but it helps us to look at this through the lens of this study and say, it's probably safer to use micronized progesterone than the progestin. And based on all the other things we know about MPA, I would never recommend using that in the first place. So we don't have a large enough randomized control trial to be able to say for sure that it does not cause cancer. But we do have some other large trials that we can look at. So the French Cohort study is a well talked about study. This is from 2009 and looked at over 3,000 women. Now in Europe, estradiol gel and micronized progesterone is a popular way to use HRT. So this is a study that was followed this cohort of over 3,000 women for 9 years. So again, big enough, long enough to identify breast cancer diagnoses. And this is exactly what they looked at. Was there an increased risk in this population of micronized progesterone and an estradiol gel with an increased risk of breast cancer? No, there was not. In fact, it wasn't even close. Okay, so what does this mean? Well, when I look at articles like the very first one that we mentioned, this article that came out in February that caused a lot of fear in my patients because it kind of says that micronized progesterone is associated with an increased risk of cancer. I never blame authors for doing this, but I think what happens is that you get authors who are certainly influenced by, everybody is, influenced by the environment around them. And you want to, as a clinician, as a physician, you want to be able to kind of stick within, the guardrails of the current thoughts and beliefs of what's happening in the world around you. You don't want to stick your head out too far because if you do, you might get it cut off. Right now, there is an overwhelming still push and influence that hormone replacement therapy causes breast cancer. I look at the progestins as likely the causative agent. Some people lump micronized progesterone in there as well, just to not have to defend it and not have to have the argument and just say, look, this is what we use. We just need to, not use as much of it and not use it for long. But I think that's a disservice to women because if we have a safe alternative that is safe for the uterus, safe for the breast tissue, and doesn't increase our risk of cancer, we really should lean on that rather than leaning into the dogma and bias that we were trained in. So from my perspective, micronized progesterone does not demonstrate an increased risk of breast cancer. The study they cite is not compelling because it was a mixed group and we can't tell if that signal is coming from the micronized progesterone or not. And when you look at the PEPI trial and you look at the French Cohort study, we do not see that signal, and this is clearly looking at micronized progesterone alone. So from my perspective, topical estradiol, micronized progesterone orally is the combination that we want to use to reduce the risk of HRT and maximize the benefit. And even if there was a very subtle, rare increased risk, then we always have to still then calculate that risk with the potential benefits, especially for my patients, my followers, people in the osteo collective. If you have osteoporosis, this is a different equation because we know what the risk is of osteoporosis and fracture, right? We know that if you have a hip fracture, you have a 30% chance of mortality within the next 12 months, 60% chance of either death or losing your independence within the next 12 months. And of those who actually, quote unquote, regain independence, they're not the same. I remember of all the patients that I treated for hip fractures, one that bounced back likely to where she was. Sorry to interrupt this video, but if you're struggling to put together your own program for osteoporosis and you haven't been to our masterclass yet, please come join me in our masterclass. It'll take an hour of your time. It's where we go through our top 5 mistakes that we see people making on their bone health journey every single day in our practice, in our community, in our comments, because we see these same things over and over again. I want to time collapse this journey for you. So come join us for the masterclass, link in the description on YouTube, or you can go to our website at osteocollective.com and you can learn about our community and sign up for the masterclass there. So a hip fracture is a big deal. It has a high mortality rate, and it is much more common for those with osteoporosis than is a diagnosis of breast cancer in women who are using HRT. I'm not saying that all women with osteoporosis should be on HRT. I'm just saying that we have to use that lens to have the right risk-benefit equation. You have a rare risk on this side, and you have a common risk of fracture with osteoporosis on the other side that has a very high mortality rate. So you have to make that decision yourself. That's it for this one. Remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is a beginning. I'll see you in the next video.